I've got a pretty snazzy, exciting title for the last talk when you're all tired and want to go home, called Evaluating Infection Control Policy Change Using Molecular Genomics. Try saying that after the drinks tonight and you'll still be right to drive home. I came up with this title here instead. This is awesome, because it is. This is really exciting as well. And over the next 20 minutes or so, I'm just going to lay out an interesting example of how we are using whole genome sequencing and molecular genomics to ensure that policy changes that we're making at Royal Brisbane are safe and not harming patients, and then also talk about a few niche, super useful applications for whole genome sequencing that we've had in the last year or so. The problem we're trying to fix here, whenever anyone tries to come to me with a proposal now, I'd always try and say, what problem are you trying to fix here, just to make sure there is one, make sure it's just not going around in circles. So what we're getting now, obviously all the time in the infection control journals, is a lot of evidence, a lot of new literature saying we should change our practice to do this or that or the other. How do we know that that is safe and is going to be safely implemented in our hospital, with that concept of us wanting to avoid harm and avoid infections in our patients? So some of the new ideas that have come around recently are that we maybe are overusing contact precautions. So that's the gowns, the gloves, the single rooms, the patient-owned bathrooms, and doing that for organisms like non-multi-resistant MRSA, VRE, the multi-resistant gram-negatives like ESBLs and CPE. So there's a lot of evidence now that patients that go into contact precautions in a single room have some adverse healthcare outcomes from that. So things like the fact that they get less OBS done than patients in the general ward. They're more likely to deteriorate without recognition than patients in the general ward. They're way less likely to be seen by their surgeon. Like 1/8 is frequently reviewed by their surgical team and less reviewed by the medical team. In one study, there's even an increased risk of death just being in contact precautions in a single room. Some of our physical ward design in some of the, Royal Brisbane was planned in the late 90s and built by the early 2000s around a different paradigm of hospital design. So a lot of the single rooms are right down the end and are really there mainly for palliative care reasons. They were never really put there for infection control purposes, and they're pretty isolated and hard to see. We are very keen to stop routine isolation. I'll go through why this is now, because we think it'll have some big benefits for patients, but of course we don't want to lead to multi-resistant organism outbreaks as well. Another example that I'll cover is we think that gloves are a great idea, so staff wearing gloves when they do contact precautions to stop transmission of organisms. But in fact, there's really, really much stronger and stronger evidence now that gloves are part of the problem, not the solution. Do any of the non-infection control nurses know why that is? Why are gloves such a problem? It's a behavioural human thing. So.
People think because their hands are still clean, they touch people and then they go on to touch other things.
Yeah. So sadly, being humans and being the selfish little buggers that we are, we put the gloves on to protect ourselves and our families. We wear the same pair of gloves from patient to patient to patient, so we're not going to get infected. When we go and have afternoon tea, we take them off and put a new pair on. But unfortunately, there's some evidence of there's a VRE outbreak in Victoria where removal of gloves from the infection control protocol seemed to terminate the outbreak, and there's more and more evidence now that gloves for contact precautions used routinely are a bad idea. We're not talking about standard precautions. If there's fluid, body spills, that sort of stuff, you definitely need gloves for those, but when they're used for dry care, for contact precautions. What about implementing new cleaning approaches? So if you're going to put a whole lot of expense into a new cleaning product or maybe a new way of cleaning, how do you know that the cleaning quality is up to scratch? And then finally, I'll give some examples of when you think you've got an outbreak, should you go the whole hog? And we're just convening an outbreak response meeting just at the moment. I'm going to run off and do that. That's not why the day's running short, by the way, but it's a lot of effort. It's a lot of effort to convene it, and I reckon the salaries of the 14 people that are just about to meet after this will be, $10,000 by the time you count all of the additional emails that have been flying around today about this infection control problem that's just emerging. So it's a pretty expensive thing to do, actually, and whether you need to do that or not. So where did routine isolation and contact precautions for non-multi-resistant MRSA come from? So the CDC thought this up in the 1970s. They suggested that this would be a good thing to do, and forever, since I certainly started practicing, isolation and contact precautions for MRSA has been absolutely the norm in most Australian hospitals. There are obviously a lot of reasons for going into single rooms. For the other MROs, for influenza, that's a really big one for us and probably for all of you as well. And also that there are other uses for single rooms, confused and delirious patients, particularly patients at the end of life who would really like to have a single room for their well-being and benefit for their family and also for the other patients. As I mentioned, there's plenty of evidence of harm of routine contact precautions with less OBS, less contact with the medical and surgical teams, and one study showing increased mortality. And also, since the 1970s when the CDC proposed this, things are better in hospital now. We have alcohol-based hand rubs, and whilst hand hygiene is not ideal, it's substantially better than it was, and the availability of alcohol-based hand rubs means it's much easier to do much more quickly. We have much stronger surveillance systems now, routine surveillance. We have hand hygiene auditing, mandated auditing, and a much better idea of what's going on. We're better at environmental disinfection. We have central line insertion bundles and a whole lot of additional infection control that we used not to. So this group and a few others have looked at the idea of discontinuing routine contact precautions for multi-resistant organisms and did a systematic literature review and meta-analysis. And luckily they got the right result, and also they found the other way. They found really that there's no risk in stopping routine contact precautions for a range of MROs. This covered MRSA, VRE, and I think it was just MRSA and VRE from these ones. There's always caveats to this. I don't know if I got here. So there's always caveats to this. This study, there were 7 good quality trials in this study, but only 2 of them used any sort of typing to look at if transmission was occurring or not. And in fact, both of those used pulsed-field gel electrophoresis, which is an old-fashioned typing mechanism, which was pretty good in its day, but just really wouldn't have the resolution to pick up if transmission was going on. You used to do a lot of PGFE, didn't you, in the old days? That's your crab paper, isn't it? Or no?
That's a long time.
Long time ago, yeah. Well, yeah, it was good when in its day, but it's just fairly low res. It's pretty fiddly, I understand, as well. So, yeah. So I'd say that this group have actually, with their meta-analysis and the individual studies, shown that this is safe without any way of actually seeing if there's transmission going on or not. So if you were going to implement a change like we did at Royal Brisbane about 18 months ago now, 12 months ago, 18 months ago, where we're not going to so we no longer routinely isolate non-multi-resistant MRSA, what outcome measure would you choose? What would you look for to make sure it was safe? What would you measure? What would you report back to your infection control committee?
Incident rate.
The incident rate of
new infections.
New infections, yeah.
Like, say, if you put it in, say, June, look at 6 months to December, and then look at the previous 6 months or the corresponding 6 months for the year before.
Yeah, sure. So that's exactly right. So we would look for...
Are you looking at your burden as well to see whether you've got underlying burden? Because that will implement how many clinical infections you have.
I think all of that. The challenge is, though, if you just went with microbiological means alone, we have a lot of non-multi-resistant MRSA. We see it all the time. It's pretty common for patients to bring it in. And just because we saw 2 cases of non-multi-MRSA on the same ward at the same time, even if they had a similar antibiogram, there's no real way of telling you if that was a transmission event or not. What you can do with whole genome sequencing is measure the key thing we're trying to prevent in infection control. So you can measure transmission events. It's a very different thing to measuring multi-resistant organisms, because you can, for the first time, with real satisfaction now, say that Mr. Smith did transmit this organism to Mrs. Jones between beds 6 and 7 with high reliability, which was something we haven't ever really been able to do before, even with pulsed-field gel electrophoresis. You got a bit of a guide, but it wasn't probably accurate enough, particularly at that low level. Non-multi-MRSA is a particular problem as well, because there's a lot of transmission in the community as well, which I'll show you in a moment. And it's mentioned the meta-analysis I showed you had only used pulsed-field gel electrophoresis and PCR ribotyping. Your study was ribotyping, wasn't it? The crab study.
There was a bit of everything.
Bit of everything in it, yeah. So, microbiology using relatively low transmission events might tell you that it's, say, a zebra or an MRSA, but it really doesn't tell you that it's Bob the zebra from Zebraville down the street. And I actually stole this idea from Patrick, and I couldn't find your slide, so I quickly went to Google and did low-res, high-res on Google, and that's how I found it this morning. But it illustrates the point. You need a very high-resolution tool. The closer two patients are, the closer the event you're trying to measure, the more high-resolution you need to pick a difference, basically. The outcome, the policy was implemented. We looked at non-multi-MRSA transmission in a lead-up for about 6 months, I think, and showed that there'd been one transmission event in the lead-up, so we were already doing pretty well, and there'd been 10 squadzillion patients with non-multi-resistant MRSA, and we've been monitoring it since then by using whole genome sequencing, so the QGHA kindly sequence all of our non-multi-resistant MRSAs, and every month we're very pleased to get reports back saying there's been no evidence of transmission, so no new cases arriving in the hospital that are matched. There's no transmission clusters, I think probably what we talk about most, talk about the clusters, and we've had none since then. That implementation of policy change has resulted in a 52% reduction in isolation bed days over 12 months. That's a massive, massive result for us. So that means basically freeing up 4,600 single bed room days. The amazing team from the QGHA and Tom and the team have done a complicated economic model around this that I don't fully understand, suggesting that the whole genome sequencing component of this intervention has contributed individually to 310 patients and 1,547 bed days, and that's making assumptions about how much additional safety the whole genome sequencing provides over just standard microbiology. It's thought after you pay for all the sequencing costs that over a year this has saved the hospital about $131,000. But more importantly, we implemented this just around the time of the great, well, it was the previously great, it's no longer the second greatest flu outbreak in Queensland history in 2017. We put that implementation in just as we were going to an incredibly bad bed crisis with flu, and it really saved the day because we were saving about 20 beds per day that we could then put flu patients into instead, so it really saved the day. And we're really sure now, we are writing this up by the way, everyone keeps on asking, but we're really sure that we haven't caused harm and there's no outbreaks. You think it's all going really well, and then Patrick emails you. Patrick has just ducked out, but he emails you just a few weeks ago saying, after a good run, I'm afraid there has been a likely transmission event to ST93-MRSA, which are closely related, only 2 SNPs apart, one of which resulted in a bloodstream infection. And you're like, oh, great, that's good news. Sorry for the bad news, exclamation mark. I think that's sort of the handoff as well. That's right. Sorry for the bad news, good luck, I'm off to the pub. So we were initially very downhearted by this result. I have to say that would have represented a single transmission event since we changed the policy, so it would have actually not increased the baseline of transmission over what we'd already seen. But we did some snooping around. Oh, there's Patrick. Yep, and then Trish got back to Patrick and said, thanks Patrick, Lauren has looked into the admission history for both these cases and it does not appear to be any crossover points at Royal Brisbane. It may be drawing a long bow, but they are from the same suburb. Kind regards, Trish. So polite. This is the report we get. This is what the QGHA send us monthly for each. So we get a report for MRSA, for VRE, and for the gram-negatives. And it has an executive summary, which has all the important results in it. And there were 6 non-multi-resistant MRSA isolated in that period. So that's about right. So it's only, this is actually a shorter one. It's only 2 weeks because I think a few people away for the school holiday, so we bunched a few of them up. And that was 6 MRSAs, is about normal for us, so about 12, 15 per month or something like that. And there was a clustering of an ST93 blood isolate with a previously sequenced isolate from Royal Brisbane Hospital, and they're like, oh, bugger. Anyway, but Trish had already picked up on the fact that they had the same postcode and in fact the same address. And we snooped into it a little bit, and it appeared that they overlapped each other by 6 days in hospital at one point. They were in different wards on different floors, although complicating that, one was a very unwell renal patient who had been visited by at least 13 medical teams, plus a whole lot of allied health, and had moved around a lot, and then unknown movement in the hospital to medical imaging. They'd both been to medical imaging cafes, the lifts, etc., etc. But it got really interesting when I put their address into Google Maps and found that they lived barely 400 metres from each other in this suburb, and they'd also both been referred to the community PACS team, and we think probably it's much more, we haven't found any actual crossover in the hospital, and we think it's probably more likely that's where the transmission occurred. It certainly goes well for the story. I put it in there partly to show how complicated this is, and partly to show that for a lot of these organisms, this is something that's happening all the time now. We've picked up a ST131 ESBL outbreak in rural Brisbane that actually wasn't in rural Brisbane. It was just one of our major feeding nursing homes, and all of the patients were from a nursing home. That was really tricky to investigate because the index patient actually wasn't in the nursing home. They didn't get admitted to the nursing home until after they'd been in rural Brisbane, so they didn't come up as a nursing home resident. And I actually went through the 193 pages of their medical record and noticed that the very last line was patient's wife is in this ex-nursing home and the patient wasn't been placed there, and he was eventually, and that's how it turned out. But in fact, that was a nursing home outbreak that we then detected from whole genome sequencing. Is there anyone from public health here, or...? Because we then wanted to hand this off to public health, and just maybe vaguely hoping that public health might come to the party a little bit more than they did on this occasion to help us with the non-hospital outbreaks. Okay, so that's just a bit of a quick example of using this. So we're going to roll out the next few phases of our plan. I'm hoping that we're going to combat VRE next year, and we'll be having heaps of opportunities to detect transmission because we have a lot of VRE in our haematology, oncology and renal wards, and so we've got a lot of isolates going into the QGHA program. Well, we've been monitoring those for 2 years now, so we've got a lot of baseline data about transmission. We don't get much VRE transmission in our hospital. Most of it seems to be de novo or possibly in the community and out there, and then we'll be able to watch that and see if there are increased transmission events once we remove contact precautions for VRE. VRE is a bit of a holy grail for mine because it does seem to take up a lot of very critical beds in our hospital and causes a lot of problems with patient movement. We then probably will leave CPE right to 2022 or 2023, and I'm a bit nervous about that, so yeah.
Are you just concentrating on clinical isolates, or is this surveillance swabs?
Any swabs as well, yeah. So they're mostly surveillance swabs. There are some downsides here that you're probably sort of picking up on. One is that once a patient leaves hospital, that's the end of the micro for that admission. Having said that, 25% of rural Brisbane patients return within the same year back to hospital again, so we do have an opportunity, and many of these complicated patients with MRAs do get repeatedly screened over years to years, but it's not perfect. It would be much better to have daily screening or discharge screening. It's pretty hard to pull off in practice though, so it's not perfect, and we could miss transmission events that way. I think as the project runs longer and longer and we don't see transmission events for sort of 18 months, it just really suggests that what we're doing is pretty safe now. The next important policy change that we're very keen to implement is not using gloves for routine contact precautions anymore. So we've already removed it for non-multi-resistant MRA. There's the idea of taking away gloves altogether. We've been running a trial in our Wattleborough Infectious Diseases ward for some months now with no evidence of transmission, and that's just started in 5C now, our haematology oncology ward, and we're slowly stepwise rolling that out to the rest of the hospital. Up until previously, we just kind of would have to monitor infection control results, see what isolates came up to see if this was safe or not, and fret about it a lot. What we can do really now, as we roll this policy change out, is look again for transmission events. We can say where they're happening and look for them. This will be much better to monitor because we can use all three, MRSA, VRE and the gram-negatives, to monitor this policy change as well. So that's happening now. And again, most of the studies that have looked at this haven't used any high-resolution sequencing, like whole genome sequencing, to make sure it's safe or not, so I don't really know. I do have a confirmation bias here, which is I think this is a really, really good thing to do. There's some we've already got some evidence that hand hygiene improves a lot when people take out the gloves. So that's what we're doing next.
Is that just for MROs, or is it for like original?
It's a good question. So we think at this stage it's for everything. So for MROs. No, the trial is for everything, but it's for wet care though. So with Nora, you'd assume you'd have wet care. So yeah, so it's just for dry patients. For standard precautions, you very much still wear gloves. So yeah, for a patient with diarrhoea with norovirus, that would be the trigger for selection. Yeah, yeah. Okay, so just wrapping up here, this is sort of what I think is the absolutely most useful part of whole genome sequencing for infection control of all. And it's this really basic question about should an outbreak be investigated. And I guess one of the things you talked about in the PA one outbreak was really what would have happened if you had whole genome sequencing at the beginning of the outbreak. I think this sort of shows what would happen if you had that, and also how you can save resources as well. So about 2.5 years ago, with our duodenoscopes for ERCP, so they're like a usual endoscope that you stick down people's throats to look at their stomach, but they have a little side viewing camera, a little port that comes out the side so they can look into the bile ducts as well, and there's this little elevator that opens up so you can do that. And we routinely sample the scopes to make sure that the processing and sterilisation is effective, and we were very upset for the first time ever. You're always doing literature researches when anything comes up in infectious diseases because there's nothing to really tell you what to do at this stage. We found this very resistant Enterobacter cloacae on one of our side viewing duodenoscopes, noting that it's a European resistant strain up here. And we thought, oh bugger, that's not good, partly because there'd been a extreme concern raised in the States after some deaths from Enterobacteriales, bloodstream infections complicating ERCPs using Pentax side viewing duodenoscopes. And so we convened an outbreak team and went down to executive and had a big discussion about it, and thought we'd look through all of the patients that had had that scope used on them in recent months since its last sterilisation. And very sadly, we found that a elderly woman had a scope with this duodenoscope, and then within days had developed an Enterobacter cloacae bloodstream infection, 2 out of 2 bottles, 11.6 hours. Very, very concerning now. I was on the phone to this patient and for 28 others who'd had the same scope used, and we really thought we had a major problem here. She survived. She lived. It was a bit gnarly though. And then the whole genome sequencing came along. Oh, that's Houston. We have a problem. Sorry. Yeah. And I guess, yeah, so what is the main question here that we want to answer? What's the urgent, critical question that everyone wants to know in this situation? Are they the same? Exactly. And very pleasing, they are nothing like each other. They didn't even look anything like each other. So, admittedly, one of them, the isolate from the patient's bloodstream was meropenem susceptible, but given the concern and angst about this case, we were very, very reluctant just to accept it based on that. A lot of the other susceptibility was the same, but and this was the pre-QGHA days, and the UQ were able to sequence the isolates for us and really show us very definitively that they were totally unrelated to each other, with over 30,000 SNPs of difference, and it meant we really calmed down a lot, and there were no consequences from this duodenoscope contamination, and we've improved our cleaning systems, and we haven't had another one since. So that was a really practical use. And we all thought that UQ and Patrick, and I think Brian was involved in this one as well. It's a long time ago now. We thought you were all... and Amy Jennison actually as well, that's right. So Amy Jennison was involved in one. We thought she was pretty super after that, a superwoman who could tell us just with the power of genomics that we didn't have a big problem, and it really just made us feel a lot better about everything. So Patrick and Brian were pretty fabulous as well. And this is another example from this year. We have Queensland's largest, one of Australia's largest allogeneic stem cell transplant units at Royal Brisbane Hospital. Incredibly vulnerable group of patients who are at probably higher risk of dying from bloodstream infection than any other population. Two, within days of each other, had a Hickman's line, so that's sort of the tunnel central line that goes in up here, inserted by the same interventional radiologist in the same unit. And I got an email from Trish, I think, investigating 2 different BSIs. I've noted that 2 BMT patients who have their Hickman lines inserted by the same practitioner have had a staph hominis identified on 2 sets of blood cultures each. So that's the first patient there. And that is that there were 2 isolates. That's the 30th and 31st of July, 2 patients, separate days. So we think this is real, it's not just a contaminant or anything like that. And patient 2 on the 2nd and the 5th of August, showing 2 isolates of the staph hominis with very similar, identical susceptibility profile. And we thought, hang on, what's going on here? Have we got a rogue inserter of Hickman's lines that's contaminating everything? We're getting ready to go. What do you reckon? Given the tenor of my talk so far. They're completely different. They're completely different. So quite dramatically, their ST type was different, and they had a lot of different genes. And again, we were able not to go bells and whistles, not get all excited about it, and accept that probably a lot of our haematology oncology patients get staph hominis bloodstream infections. Now, of course, we can't still be sure that this hasn't been related to poor infection control standards in the medical imaging suite, but at least we know that there's not some sort of individual practitioner disaster going on here. So that was a really pleasing and reassuring result to get. And I guess just again shows the power of whole genome sequencing in calling things off, calming everyone down, showing there's not a problem. It's a bit of a recurring theme for me, but I think a lot of the power of this technology is as much about what we won't have to investigate and won't have to run away for as much as what we do have to. I always remember an outbreak of pertussis at a children's hospital south in a different state, where I think 78 people were put on azithromycin and over 400 were screened. And then at a clinical meeting, one of the microbiologists said, "Oh, what initial test did you do on the baseline patient?" And they said, "Oh, it was a pertussis IgA on blood." And he said, "Didn't you know that's a terrible test?" And it turns out it was a false positive, and they'd spent several $100,000 evaluating this non-pertussis outbreak and put 78 people on azithromycin. So not doing stuff is good as well, because it keeps us free and resourced up. And also, when we put these into the economic models, not investigating outbreaks and saving staff workload is actually one of the big economic benefits of all of this. So, I guess just in summary, next generation sequencing offers a extraordinary resolution to answer just a really simple question. Are these two isolates the same? And therefore, was there a transmission event or not? It's a really simple question, and one we probably thought we could answer, but actually this is the first time we can actually answer that question with any degree of certainty. And it makes a big difference. Not always. In fact, in both of these cases, you could have probably picked it through other techniques, but I think the fact that it happened quickly in real time at very high resolution and highly reassuring gave us the confidence that there wasn't a problem that we were dealing with. The reason I love this is it's a really objective outcome measure. It's not just another measurement of process like hand hygiene compliance or cleaning audits or aseptic technique competency assessments. It's actually something hard that you can really look at. So I can pretty confidently say we don't have a problem with hygiene in our ICU, and that's because we just don't see transmission of organisms. It's a very low level event, and I know that because they're all sequenced and we know that we're not seeing transmission. There are units where we have seen transmission as well, and we can then hone in on those much more accurately and go after them, like the Burns unit when we had that outbreak, and now we can do that sort of at that level. And regardless of all the process outcomes, we can really start looking at really hard outcome measures. And I think over time, I hope this is how we measure the quality of infection control programs and the quality of the safety of our hospitals, is by looking at a number which is going to be transmission events per patient or bed day, rather than looking at process measures which are only ever going to be a de facto. Professor Sharon Peacock presented at the ACID meeting in Darwin this year and gave a similar but much better talk than mine, called The Topsy-Turvy World, Where Pathogen Sequencing Leads Infection Control. I can really see this happening. I completely agree with it. I think it's going to be a much more economically viable, cheaper and better way of prosecuting infection control in the future, is to sequence as much as you possibly can all the time and pick where transmission is occurring, then investigate that, not do the traditional style, oh, there might be a bit of a problem in Ward 4C maybe, and then call the lab, and 6 weeks later we get a few results back through with no interpretation and things. I think this is going to switch. We're going to switch, and we'll probably be front-loading whole genome. So I really hope we will, because I think it's proven itself in my view. There's a lot of implementation work to do now. There's a lot of convincing of people that this is the right thing to do, and it could be a little bit threatening as well, because it probably would be pretty disruptive for people's jobs and what they've been doing a lot of. One thing I would absolutely emphasise is I'm not remotely saying it means you can get rid of infection control nurses or practitioners. I think what we've shown today over and over is that this data is only as useful as the plumber that rips out the drain, or the nurse that goes and takes the deep swab, or the doctor that goes and speaks to the radiology department about improving their aseptic technique practices. You've got to actually have an effector to make difference to patients' lives. But that it's powerful data and it convinces people in a way that maybe we haven't been able to before. So I think that's a real strength. So the question is, can you afford not to use rapid, accurate molecular epidemiology in your hospital epidemiology and infection control? And that's all.